In this video, I'm going to discuss 6 things I consider when I am assessing any tooth for restorability. And at the end of the video, I will tell you 5 reasons when I consider indirect restoration versus direct restoration. So before we start, let's look at some of the examples which comes to us in day-to-day clinical practice. So if a patient comes to you with tooth like this, then you can fairly be certain that, when you remove the restoration, you'll have sufficient tooth to restore the tooth, as far as there is no severe caries, which you will understand with the periapical radiograph or bite wings, you will know how bad the tooth is. But by just looking at the clinical photo, you can tell that you can save this tooth. If the tooth comes like this, then you may say, you know what, I need to remove the restoration and assess before I decide whether the tooth is restorable or not. However, if the tooth comes like this, then you know that this tooth needs to come out and possibly replaced with denture, implant, bridge, or whatever patient prefers. But generally, we have an idea what to do when it comes to assessing restorability. However, I have these 6 steps which I follow when I am assessing restorability of any teeth. Step number 1 is I assess that tooth for endo and perio status. So I make sure that there is no endodontic lesion. If there is, the endodontic treatment is done to the satisfactory level. If the coronal seal is exposed, we know that most of the infection comes through the coronal seal because of the breakage of the coronal seal. I recommend patient to have root canal treatment. Now, not always patient would say yes to that, because if the tooth is asymptomatic, in their mind that they don't want to get it redone because root canal treatment is not pleasant and it's quite expensive. So they might not want to redone, but it's our duty to let the patient know that, there is a breach in seal and that can cause issue. Periodontal status, when patient tooth has a crack, you can see that J-shaped lesion where there is no pocketing anywhere and there is one point where the pocketing is quite deep. So you need to assess the periodontal status of the tooth. Obviously, if the tooth is grade 2 mobile, you're not going to do indirect restoration for that tooth. You need to let the patient know about this. So sometimes I use tooth sleuth to assess any crack in the tooth. Number 2 is I take preoperative radiograph. Again, that gives you a lot of information about the endodontic status and the bone level around the tooth. Number 3, I would consider removing all the restoration, stripping all the restoration from the tooth, and then really assessing how much of the dentine or enamel is left in that tooth before I decide whether I can restore that tooth or not. And this is something I call an assessment of the tooth. So I let the patient know that, we'll have to really remove everything and then really assess how much tooth we are dealing with. Number 4, once I have removed everything, I will then consider whether I'm going to do a direct restoration or indirect restoration. And this will depending on how much cusps are left. However, if you're really struggling to do assessment of the restorability of the tooth, that means most likely that tooth will need indirect restoration because it's very difficult to build it, that kind of huge restoration. So you would be considering indirect restoration. You need to consider deep margin elevation because that can help you with doing minimal prep and still keep majority of the tooth in patient's mouth, and that increases the longevity of the tooth. So I would consider whether I can fit my matrix band in. Is it possible I can isolate the tooth in order to do deep margin elevation? And number 6 is budget of the patient. You need to really consider, just because you can do all these fancy treatment, patient may not have money or may not be willing to spend money on that tooth in order to try and save the tooth. So this is a classic example where this patient come to you with this kind of tooth, very less amount of tooth is left. Are you going to try and save the tooth? Now, that could be a situation where patient cannot have tooth extraction because going IV bisphosphonates or some sort of a drug and you need to try and save the tooth, or for some reason patient really want to keep the tooth. Patient understand that whatever money they're going to spend on this tooth, they might end up losing it because there is no guarantee that whatever treatment you do may or may not work. In that case, yes, you can probably attempt. However, patients are very sensitive to budget in the sense that patient want that guarantee that the treatment will last, that I personally cannot give guarantee that if I do post and core restoration on this tooth is going to last, because there is no ferrule. And we know that when you don't have any ferrule, the prognosis of the post and core restoration goes down. Of course, you can do crown lengthening, you can build the tooth up, you can do lots of things, but point is that there is not enough tooth in this tooth in order to try and keep the tooth. So these are the 6 steps I follow when I am doing restorability assessment. Now let's look at 5 scenarios when I'm going to consider indirect restoration when it comes to treating the tooth. Number one is there are more than 1 or 2 cusps missing in the tooth. If I'm restoring molar and there are 2 cusps missing, then I would really try and consider indirect restoration, because it's very difficult to build those huge composite. However, nowadays the composite restorations are becoming really, really good, and I've seen some beautiful work where people are doing direct composite. However, for me, I prefer personally indirect restoration because you can get much more control of the shape using indirect restoration. And that comes to point number 2. Even though you can build the tooth with direct composite, if you think you're going to struggle with a nice emergence profile because the contact points are too far apart, you may want to consider indirect restoration to get really nice emergence profile and get a much better contact points. Number 3 is when the tooth is root canal treated, posterior tooth. If the second molar is root canal treated, then I would always consider indirect restoration, cuspal coverage, most likely using an onlay. If the tooth is dark in color, let's say if you have upper right 4, previously had a huge amalgam restoration and now gone really dark color, you can do an onlay to protect the tooth, or you can do just a composite to protect the tooth. However, patient doesn't like aesthetically that tooth, and that could be one of the reasons where you may want to do indirect restoration. Again, you can do composite to mask the discoloration, but indirect restoration will give you much better aesthetic result. And that comes to number 5, which is how long your aesthetic result is going to last. And in my opinion, in my hands, when I do porcelain veneers versus when I do composite veneers, the porcelain veneer lasts much longer than composite veneers with minimal maintenance if it's done right. So for me, I do indirect restoration when I feel that I want to make it last longer. I generally try not to do that for younger patients because obviously I know that it's not going to last them lifetime. So I try and do conservative treatment. However, much older patients, if you want to give them nicer smile, then consider indirect restoration. Of course, you need to consider invasiveness. However, with the nice material nowadays, you can prep really minimal preps for veneers and you can still do really amazing work using indirect restoration without preparing too much of the tooth. So I hope you enjoyed this video where I have gone through assessing restorability and 5 reasons why you might want to consider indirect restoration. If you like this video, then click on the link below and subscribe this channel, and I will see you in the future.